I would ask you, Satish, to go to the podium and to start on this quite exciting topic of the Envista toric, and in this case, the planning of a toric lens. Satish, please.
Thank you, Oliver. Good evening, everybody. Thank you for taking your time off your schedule to come to this evening. I'm just going to kickstart this evening with a 360-degree overview on the preparations for using toric intraocular lens in your practice. Just before I start, can I get a show of hands on how many people are currently using toric lenses in their practice? Quite a little bit. Okay. Right, these are my disclosures. I'm going to start off giving you a little bit of introduction about modern cataract surgery, look at the prevalence of astigmatism and tools which are currently available to measure astigmatism, and I'll very briefly touch upon the surgical steps and some tips. So as we all know, cataract surgery has become the most commonest refractive surgery as general ophthalmologists perform. And refractive outcomes with the modern technologies and the tools that are currently available, we can pretty much tailor the refractive outcomes to each individual patients. And as we all move into the 21st century, the patient expectations are also becoming higher and higher. And thankfully, the technology is keeping breast with that, and we have got more and more tools which could accurately measure and help us to completely eliminate or reduce astigmatism during cataract surgery. I think it's fair to say that we have come to a stage where just removing a cataract and putting a monofocal lens without addressing the pre-existing corneal astigmatism is not a done thing at all. During cataract surgery, it gives us a great opportunity for us to correct any pre-existing astigmatism so that we could give the best possible vision for all of patients and they could enjoy best uncorrected visual acuity. This is a study which is ongoing currently in my practice in Scotland. We are just tabulating the prevalence of corneal astigmatism in all of the patients who come in for cataract surgery. This is an ongoing study. As you can see, this work has just been submitted for publication. We have currently got about close to 3,000 eyes now. On the x-axis is the prevalence of astigmatism in 0.5 diopters, and in the y-axis on the top, you have the percentage of patients. And that's the prevalence of corneal astigmatism in the normal cataract surgery population in my practice. If I can give you just a ballpark figure, about almost 40% or almost close to 50% of patients have at least more than 1 diopter of corneal astigmatism. And about 20% of patients have more than 1.5 diopters of corneal astigmatism. In my view, even this 1 diopter is visually significant because I have moved to doing microincision cataract surgery, as most of us have. And the amount of surgically induced astigmatism which we induce is less, and also the amount of astigmatism which we can correct with our wound has become much less because we have all moved to microincision surgery. So in my hands, 1 diopter of pre-existing corneal astigmatism is a significant issue to address. And this is looking at all the studies which have been published so far, apart from mine, which has been just submitted. We are just looking at the percentage of patients who have had more than 1.5 diopters of corneal astigmatism. And these are all published papers out in the literature. And as you can see, Hoffman's paper from Germany has got the biggest number with about 24,000 eyes. And the other studies are closely around between 5,000 to 6,000. And you could see there is a pretty much consistency in these results. About 20 to 21% of patients have more than 1.5 diopters of pre-existing corneal astigmatism. And if you look at much higher astigmatism, like more than 3 diopters, in our group, which is looking at we are about approaching around 2.85%, and the remaining published studies are looking at about 3%. So what all these studies have so far highlighted is if you start looking at your cataract surgery population, the pre-existing corneal astigmatism of more than 1 diopters will be present in almost 40% of your cataract patients. David Leming is an ophthalmologist in California who does every year survey of all the people attending the ASCRS and the ASCRS members. And the 2011 survey, toric IOL has become the most commonest method for correcting astigmatism, although other methods are available like limbal relaxing incisions or a steep meridian opposite clear corneal incisions. And if you looked at the data between the Europeans surgeons between 2010 and 2011, the percentage of people using toric intraocular lenses, monofocal toric intraocular lenses, is on the rise. And always the percentage is higher on the other side of the Atlantic. 2011 survey of the ASCRS surgeons showed 66% of American surgeons use toric intraocular lenses for correcting corneal astigmatism. And this is the, sorry, let me go back. This is the data from 2009, 2010, and 2011. And once again, you could see the numbers gradually increasing between the Europeans as well as the Americans for the use of toric intraocular lenses. And once again, the premium IOL usage, both for monofocal torics and for multifocal torics, is also on the rise. So more and more of us are becoming more comfortable in recommending and using toric intraocular lenses for our cataract surgery population. But for people who haven't used toric intraocular lenses, and if you're planning to incorporate this into your practice, I just wanted to give you the basic steps, what you need to consider while you're planning to operate to offer toric intraocular lenses. The first and foremost is to identify the source of astigmatism, and then going to look at the way we are going to measure astigmatism, and then accurate placement of toric intraocular lens, which Professor Findle will be talking more in detail. So I'll be concentrating on the first two, on the measuring astigmatism. The source of the astigmatism this is a very important concept to remember. In a phakic eye, the sources of astigmatism either could be corneal or could be lenticular, and now people are beginning to talk about pre-existing retinal astigmatism. Accurate keratometry is very important, and the other important point to remember is while we are trying to correct astigmatism during cataract surgery, we are purely concentrating only on the corneal astigmatism and not on the lenticular astigmatism for obvious reasons, because that lens is going to be removed. So accurate keratometry becomes a very critical part in planning for these lenses, and corneal topography will also become a very critical part, and especially in your early cases. We don't want to start off with patients with irregular corneas or form-fruste keratoconus, where they will have suboptimal results following a toric intraocular lens. This is just an example which I want to drive home. This is a cataract surgery patient who was referred for consideration of cataract surgery. That's the spectacle refraction. And you could see the right eye has got a cylinder of plus 3.25, and the left eye has got 2.25. And if you do that astigmatism, what you get from your manifest refraction is a combination of corneal as well as lenticular astigmatism. If you do IOL master keratometry, and if you look at the true corneal astigmatism, you could see the corneal cylinder is only about 1 diopter in the right eye and about similar in the left eye. It's much different from what your spectacle correction gives. So whenever you're considering toric intraocular lenses, it's very important to tease these off, and we are going to purely concentrate only on the corneal astigmatism and not on the lenticular. This is another patient who's got a very high cylinder, both on manifest refraction on the right and the left eye. But if you look at the corneal cylinder, it's much less than in the right eye and in the left eye. And to confirm it, if you do corneal topography, you could see the left eye has got very similar corneal astigmatism as measured on IOL master with the corneal topography. And once again, you could see a classic regular astigmatism and not an irregular corneal surface. And this candidate would be a great one to starting your monofocal lenses. The other important point to consider is if your cataract surgery patients are wearing contact lenses prior to the cataract surgery, it's very important that you leave a good period of time before you measure the true corneal shape. Depending on the soft or hard lenses, these corneas can have a lot of corneal contact lens warpage, and it takes almost a good few weeks before you can truly measure their corneal astigmatism. And I'll just give you an example of this. This is the first measurement done of one of my patients who are wearing a hard contact lens. That's the measurement done in September. And if you just follow the corneal cylinder in the right and in the left eye, that's the measurement done a month later. The corneal cylinder has moved from 2.4 diopters to 3.2 in the right eye, and round about 3 diopters to 3.68 in the left eye. That is a month later, and it's 2 months later, it's still changing. So what it really means is there is no standard rule on when you would take the accurate measurements. My practice has been to serially do these measurements every month till I get a stable reading. Especially with hard contact lenses, it takes much longer for the true corneal shape to be manifested than with the soft contact lens. So a word of caution, if your patients are wearing contact lenses before, then it's very important that you do some serial measurements before we totally unravel the true corneal astigmatism from these patients. Next, once you have decided that patient is suitable for a toric intraocular lens, and if you have collected all the information, the next we are going to use the software from whichever company lens you're going to use to calculate the power and the toricity of the contact lens you're planning to use. The Envista Toric has got a nice online calculator. This is the very first page when you log into the internet and go to the Envista Toric calculator. You could pick your language. And the next page gives you the surgeon's name, your patient's name. You can put the patient's date of birth. And if any additional notes you want to make note of, there is a box for a free text as well. And then you can select your toric lens, and then you can select the laterality of the eye, and then you could put your keratometry readings. Here, the point once again to remember is to decide whether you're going to put it in diopters or you're going to put it in millimeters. Most of people are using either LensStar or IOL Masters, so we are all used to diopters. And once again, depending on the machine which you use, most of the IOL Masters have to be calibrated for their refractive indices. Some machines in Europe have different refractive index than to what we have in the UK. So it's very important that you pre-select the refractive index which you are going to use, and then you decide, and then based on the measurements you collect, you put in the values for the steep meridian, the axis, the flat meridian, and the axis. And it will be a very useful data, especially if you're moving into toric intraocular lenses, to know what your surgically induced astigmatism is, because this becomes a factor when you're putting it into the software to calculate the power of the toric lens. And then you could put in the mean sphere power which is required. If you don't know your surgically induced astigmatism, you can default it to 0.5 diopters. And then once you feed all that information into the computer, then it calculates the power of the sphere and also the power of the cylinder, and it also gives you, that mark gives you the incision location, and it tells you which is the flat meridian and the steep meridian. And this is the calculation summary, which gives you the pre-op corneal astigmatism and what the residual astigmatism you could expect after the operation. So the basic steps, as I told you, the first step is to measure, and the second step is to mark, and the third step is to align the intraocular lens to the mark while the patient is on the table. The steps for toric IOL intraoculation: the first step is for the reference axis marking, and then you have got the alignment of the lens to the axis marking, and then fine-tuning the IOL alignment while the lens is inside the capsular bag. The reference axis marking is one of the most critical steps after you have measured. The important point to note is patients should be sitting upright while you are measuring astigmatism. All the studies from the refractive surgery, we know that when the patients lie down from the sitting position, the eye undergoes torsion, and this almost causes 10-degree error. So it's very critical to mark these patients while they are sitting upright rather than lying down. And we'll just go through the number of different ways you could mark your patients. A note of caution here, just to give you the degree of misalignment you'll get. 1 degree of rotation will cause 3.5 degree of toricity to be lost from the intraocular lens. So if you're misaligned by 30 degrees, you almost completely lose the effect of a toric lens, and that lens just becomes like your standard monofocal lens. So it's very critical that you try to eliminate this degree of misalignment. So the alignment of the toric axis, you don't want this big blub of marked ink marker on the eye, so that when you're aligning your precision toric lens, you don't know which mark to align. The standard the standard device which most people start off is a Mendes gauge, where you could see the marks are in 10 degrees increments. So it goes from, for example, 30, 40, 50, 60, and then you start guesstimating when somebody wants an axis at 35. Hunkeler-Mendes gauge is a slight modification where it goes in 5-degree increments. So this is something which is a bit more accurate than that and gives you a bit more precise measurement for marking the steep meridian while the patient is on the table. There are different markers which are currently available in the market. My favorite is to use as thin a marker as you can get. The more thicker the marker you use, you get a bigger blob, and then that can cause alignment errors. So thinner the mark, better if you're starting off with this fine tip pen. Once again, you want to try to eliminate these kind of general marks. You want a much more aligned mark. And there are several axis markers which are currently available in the market. Just to give you an example, this is the Whitman axis marker. Once again, at the back of this, you could mark with a marking pen, and you could align the axis, and then you imprint this on the cornea, and it leaves a toric mark. And there's another, STARS makes a toric bubble marker, which once again eliminates any misalignment while you're marking while the patient is sitting up. This bubble helps you to keep the instrument straight and in level to avoid any parallax error. Goder makes some corneal markers, which, like an applanation device, you could put it onto your applanation ring, and while the patient is sitting on the slit lamp, like a Goldman marker, like a Goldman tonometer, you could mark the steep meridian. This is another one which is currently available from Ocotome as well. So the important critical part is to get the alignment correct and with the patient sitting upright. Of late, I've been starting using this eyepiece from Hackstride, once again, which has got a bubble mark which helps you give you the orientation. And looking through the eyepiece, it has got a reference mark, and it has got a nice horizontal axis which goes through the horizontal meridian of the patient's centered pupil, and then you could mark the axis by looking through the slit lamp. So once you have marked the patient, then the next critical part is the IOL alignment. I'll just quickly skip through this video. Professor Findle will be showing more of these, but what you want is a nice toric intraocular lens centered within the capsular bag, and these marks are the toricity surfaces marks on the posterior surface of the optic, and that should be aligned pretty much straight with the steep meridian of the cornea. Some fancy devices are also available in the market, one of which is an intraoperative wavefront aberrometer, which is
wavefront aberrometer and the orange analyzer. The system is comprised of an aberrometer that is attached directly to the surgical microscope and connected to the orange processor and touchscreen monitor. During the procedure, the physician captures wavefront images of the patient's eye. When a wavefront image is taken, a narrow beam of light is directed into the patient's eye and is reflected off the retina. As the reflected light passes back through the optical elements of the eye, it produces an aberrated wavefront. Orange analyzes the wavefront reflected out of the eye by relaying it through an optical system and directing it through a pair of gratings set at a specific distance from and angle offset to each other. This creates a fringe pattern that is captured by a camera and processed using proprietary mathematical algorithms to calculate refractive values based on the aberrated wavefront. The orange intraoperative wavefront aberrometer provides a real-time analysis of the refractive status of the patient's eye at any point throughout the surgical procedure. Surgeons can use orange.
So this is an intraoperative aberrometer which helps to accurately calculate the refraction of an aphakic eye and also helps in the toric alignment. Just going to quickly conclude by telling, once again, I want to reiterate the point that we are going to measure and treat only the pre-existing corneal astigmatism when considering toric intraocular lenses for cataract surgery population. Meticulous preparation is essential in marking these steep meridians, otherwise we will induce error during the process. And Professor Findle will talk to you more about how to accurately place the toric IOL in the steep meridian with the pre-aligned marks while implanting toric intraocular lenses. Thank you very much.
There we go. Thank you. So I just want to talk to you about the actual alignment process, and then at the end say a few words about the platform, the Envista platform, and just a few words about the Envista Toric. Next slide. These are just my financial disclosures. So here you've sort of seen this to a certain extent. This is the trial which, a study which was already alluded to, which by Hoffman, showing that we have quite a few patients with significant astigmatism in the cataract population. And that also is a reason why we are increasingly using toric IOLs or also incisional techniques. So we've spoken about identifying the steep meridian, meaning measuring the cornea, calculating the toric power, and now I would like to talk about marking the meridian some intraoperative pearls, and we'll have some slides later about the actual stability. So here, that has already been said, 1 degree off means about 3% loss of your toric power. So that's obviously very little, but if you are 10 degrees off, and that's only a millimeter at the limbus, that's not very much, you already lose a third of your toric power, but you still may have a happy patient. But if you're more than that, I think then you're in trouble, because not only does the patient he still has the same amount of astigmatism, but he actually also has an axis flip, which patients usually don't like. So really it is about trying to stay definitely below these 10 degrees off alignment if you want to have a patient with a relatively good outcome. Next slide. So obviously exact placement is critical. Now one of the problems is cyclotorsion, which has already been described, and on average that's about 4 degrees. And actually there are outliers in the literature which go up to 17 degrees. And also, even if you think that the patient may not have cyclotorsion, or you don't care about cyclotortion, if you don't mark the patient beforehand, you have a problem, because usually the patient will already be draped, and then you have to actually align the lens or align the horizontal. It's actually not even easy to say that after draping. What is the horizontal in this patient? Next slide. So here, just from the literature about just cyclotortion, and you can see cyclotortion 2 to 4 degrees and outliers up to 17 degrees. So this does happen, and it can be in or ex cyclotortion, and that will depend from patient to patient. Next slide. So what we do currently as our standard protocol, because it's pretty straightforward and simple, we just use a slit lamp. And now that may not work in all centers, because sometimes you don't have a slit lamp available in your operating theater or close to your operating theater, but if you do, I think that is still the most straightforward procedure. So what we do is we ensure that the patient has a straight head position in the slit lamp. We take just a normal, long, thin slit, and we make it horizontal and have it retrograde. So then we have a nice line through the center of the pupil. We obviously try to center on the pupil. And then we use an insulin syringe or a subcutaneous needle, and we actually mark the horizontal at the limbus. We make 2 small microerosions, small scratches. And typically what we will do is actually we will put some blue color on those, because otherwise you may, if the patient doesn't go to the operating theater straight away, but maybe to the operating theater after half an hour, after 1 hour, you may actually have difficulties finding these small microerosions. So it's good to just put a blue blob on top, but you will still see the microerosion, so that is very precise. And that for us has worked very well. Typically we will just mark the horizontal 0, 180, and sometimes if we had difficulties doing that, we may also take a 90 degrees meridian. Well, what I also tell this is done by our trainees, so we train up the trainees, so they have to do a few of those to have the first learning curve, and then we check them, and if they are really horizontal, what they do is, in each patient which they've done, they recheck at the very end, and if one of the 2 marks is not exactly in the horizontal, they will just put that on our IOL master printout. They will just indicate temporal blob, or temporal, in that case, microerosion, is 0.5 millimeter below. So that's good for the surgeon, because then you can take that into account when you're actually doing when you're using the Mendez marker intraoperatively. So these are the kind of markings you see here. Now we've done a trial where we've actually compared it with other marking devices. So here a pendulum marker. Next slide. And then here with the Newit's Lane bubble marker, which you also put blue into blue ink and then have a bubble, and it gives you 3 markings. And the tonometer marker, which was just alluded to by Goyder, the 2 mark. And next slide, please. And what we did is we just had trainees who had the same exposure and the same training with each of these markers. So they had 15 goals they had with each, actually mark patients. And then we took photographs straight afterwards. And you can see what we looked at is obviously the actual rotational misalignment and also the vertical misalignment, because that can be quite troublesome if you're in the operating theater, even if it's horizontal, but it's slightly off, either vertically below or above. It can make it more difficult during surgery. Next slide, please. And what you can see here is that actually the pendulum marker did very well. Next slide. I'll show that as next slide, as box plots. Next slide, please. So here you can see that the box plots for the slit lamp, pendulum, bubble, and tonometer marker are actually, these 2 are pretty good. There is a difference between the 2. The pendulum marker doing better than the slit lamp. but actually the other two in our hands were worse. We had more variability. So from our point of view, that means if you're in the operating theater, we actually use the pendulum marker if the patient was not marked beforehand, but still we actually adhering to the slit lamp marker. Next slide. Because it turns out that the vertical misalignment was actually the best with the slit lamp. Next. So here as a box plot, you can see that the vertical misalignment was least with the slit lamp. So for us, from that point of view, that was the most practical to use and also very precise. Next slide. So if you want to get really a more technical and more fancy, the way to go, and there is a few systems out there now, the SMI system from Berlin, which has now been acquired by Alcon, and this system, which I'm acquainted with from Zeiss, which is going to be marketed this year, if I'm correct. They use an IOL Master 500, which is slightly adapted, which takes a photograph of the vessels. So this is a red-free photograph, and the vessels are photographed when you do the biometry. Next slide. And what you can see here is that this image is imported into the computer, which is connected to the Lumera 700 microscope. Next. And the alignment is made between these vessels and the live image from the microscope, and the surgeon sees through the right eyepiece a superimposed image of the lines of alignment. So that's quite neat because you don't need to look to the monitor. You can actually do everything straight through the microscope. Next slide. So here you can see, for example, this is an example with this vessel here, and obviously all these vessels are recorded. Next slide. And then this is a superimposition of the live image of the operating microscope and the photograph taken at the IOL Master before surgery. And you can actually see the vessels. This is sort of the limbal, the perilimbal area put into a straight line of the two photographs, and you can just do a double check. Next slide. And then this is the kind of image you see as a surgeon. You see the horizontal line, and you see the superimposition of this, in this case, the meridian, which we're aiming for, which you obviously have to enter into the system. And then you can align and there's a tracking system. That means if you're moving the eye during surgery, this will track and auto-track all the time, and you can align very precisely. Next slide. And again, just to remind you that 10 degrees, which we said is really the limit. I mean, you want to go definitely below 10 degrees if anything possible. I think you should aim for 5 degrees off at the most. Obviously, you're trying to aim for exact precision, but I think 5 is probably what you can tolerate. 10 is the most you can tolerate. Is only 1 millimeter at the limbus for a normal-sized eye. Next slide. So I think intraoperatively, obviously, this is not rocket science. This is nothing. The surgery is the same as always, so it's pretty straightforward surgery. All you need to do at the end is you need to be as precise as you can and take some time. So I think it's important that once you've implanted the lens, you really want to do a complete viscoelastic removal. I will only use a cohesive viscoelastic when I actually implant the lens in these cases, because I want to be as complete removing the viscoelastic as possible, because you don't want to have a cushion of viscoelastic behind the IOL, because that may allow the lens to rotate on that cushion within the first few minutes or hours after surgery. Also, you want to rotate, obviously, the lens to the correct meridian you can use a bimanual IA, obviously you can also use a coaxial. Then I, as I said, remove the viscoelastic from behind. And then what I do is I typically will hydrate the paracentesis and the incision, so I'll have a firm eye, and then I'll do the very last fine-tuning with a 30-gauge cannula through a paracentesis, which will allow you to really just give the lens that very little, these last 2 or 3 degrees, 4 degrees, whatever it may be, to that nudge to actually put it on the right axis. So what I'll always do is I will use the Mendez marker again. I will put it on the eye again, even though I've done markings in blue before, because sometimes the lens is not centered on the cornea. It's, typically the lens is slightly nasally, and that can be very variable from patient to patient, from eye to eye. So typically I'll put the Mendez ring on again, and then I will fine-tune as well as I can. Just a word of caution, in a high myop, you have a higher probability of having a big bag. And if you have a big bag, what you really want is you want a fully extended lens. Now, all these hydrophobic acrylic lenses with their open loop haptics, such as the Envista Toric, all of them take a while to really extend to their full size. So you have to give them a little time. Now, in a normal eye, that may not be such an issue, but if you have a very big bag, you really want to wait a little. So sometimes it actually makes sense if you have a very big eye with a big bag, and you can see the lens is moving relatively easily. You really want to give the eye maybe even 1 or 2 minutes put the lights off, wait for the aqueous to warm up, or the BSS inside the eye to warm up, to allow the lens to fully extend, and then actually do the fine-tuning, and that may make it a little more safe. Next. So this was actually my strategy about a year ago, and at that point, and I've changed my strategy slightly. What I've said is incisional techniques and toric lenses. I think under one diopter, I think there's not much of a discussion. I think incisional techniques are the way to go. You just do an on-axis incision, and I also like to do opposite clear cornea incisions in low astigmatism because I think they're quite effective and they're cheap. And then I used to use LRIs. I've actually stopped using LRIs for two reasons. I've had, well, two patients. I've had one patient with severe dry eye after that because obviously you're cutting a lot of nerve tissue. And I've had another one, unfortunately, with an infiltrate and actually an ulcer in the LRI. That was last autumn. So I'm really reducing my LRIs very, very rapidly now. And I guess that will allow us to think about using toric lenses at much lower rates. I mean, in the US, it's quite common to have toric lenses in between 1 and 2 diopters. I think with multifocals, it's something we use readily. But I think now we're getting much more sort of used to toric lenses. I believe now the toric lenses will be moving into this 1.5 to 2, maybe even 1 to 1.5 diopter segment. Next slide, please. So just to summarize the first part of the talk, which is really about identifying the meridian. I think that has been alluded to before. Incisions, I haven't shown you any data now, but we know that they're less predictable, and I just told you about some of the problems for LRIs. The toric IOLs, definitely, for me, at 2 diopters above, it's clear is where I would use torics, and I think now we're sort of talking about the area of 1.5 to 2 diopters because of the problems with the incisional techniques. But I also would recommend one thing. It also makes sense to leave a little astigmatism, at least in one eye, to undercorrect slightly. And that is because really much of patient satisfaction is about functional vision. And we know that if you have a little residual astigmatism, that can be very helpful to give you depth of field, because obviously you have some depth of field through that. And I think that's something you always have to keep in mind. You may want to keep one eye slightly undercorrected, and I think that makes sense. Marking the meridian I told you about, and placing the torus on meridian. And again, precision is really key with this kind of surgery. Now let me, next slide please, introduce you to the enVista. This is the platform. This is the now non-toric or non-toric version or aspheric version, 0 to 34 diopters. It is a hydrophobic acrylic material, obviously with a UV absorber, 6 millimeter optic, 12.5, so very straightforward. Open loop design. This material has been around for a while, so people like Manfred Tetz from Berlin have tested these materials and have long-term follow-up, and he may want to discuss that in the discussion section later, where this material has been shown to be glistening-free and also very, very stable. Now, next slide, please. This is the toric variant. And you can see these are the cylindrical powers on the IOL plane, 125, 2, and 275, corresponding to these cylindrical powers on the corneal plane. And otherwise, the design is the same. Obviously, you have 2 lines to show you the alignment axis. Next. Here again, some of the material benefits. I don't want to go into all the details, and I think most of you know this lens, so that's probably not so. But I think one of the things we are all quite interested in is that it's actually in fluid before we do surgery, so it is pre-hydrated, and we have seen no glistenings with this lens until now. And that's obviously an issue, as you know, with hydrophobic acrylic lenses. Next, please. There's also 360-degree continuous sharp edge. There is a stepped haptic, and you can see here that this sharp edge is supposed to, again, help to stop LSC progression or proliferation behind the lens. And it has a very sharp edge, which we know is important. It's not only having a sharp edge, but you want to have a really sharp edge to have this lens epithelial cell migration barrier. Next, please. This is a very nice slide from David Spalton and his group, where they took standardized photographs, slit-line photographs, did some image processing to actually look at glistenings. And we know that glistenings are very common, especially with one of the competitors. Next. So here again, some of the patient benefits of using the Envista platform. And again, I think most of you know about these, and I think most of these have been alluded to. Next. And that's actually the end. Sorry about that. Thank you very much for your attention, and we'll continue now and then have questions afterwards. Thank you.
Thank you, Dr. Finger. Good evening, ladies and gentlemen. It is my pleasure to be here and to share with you my early experience with Envista Toric IOL, in which I have no financial interest. The 3 lines pointed here in the summary have been so nicely discussed by the previous speakers, so I'm going to focus myself on the 3 remaining points: surgical pearls, post-operative results, and some suggestions or maybe take-home messages. Dealing with premium IOLs and with toric IOLs means that the surgeon has to take some extra care, and that means some pre-operative concerns and some intraoperative concerns. Pre-operative concerns, I mean, this is getting the correct K readings, and it is still a debate which is the best method to have the correct K readings. The correct biometry, and for us this is clearly the immersion and IOL master, and getting an accurate marking of the cornea. What we do at a slit lamp using the Purkinje reflex. There are also some intraoperative concerns demanded for any premium IOL, and that means perfect surgical technique, beginning with a perfect CCC, up to the final in the bag positioning. You will have, here you will see a movie. This is my very first Envista Toric IOL. From the beginning I have, let's say, a small problem. It's difficult to be seen because of this tria of the bottle. First I grabbed it upside down, and I had to put it back and to grab it once again in a better position. Now I'm looking for the markings. And then now it's very important how we put it in the cartridge. I used to put the 2 holes aligned with the central line of the cartridge. This is what I always do for Envista platform. Now it seems it's not mandatory anymore, but for sure, for safety reasons, I do it the same. And I always pay attention to the second loop to be careful, set, and put on the optic part of the lens. And now a nice insertion through 2.2 millimeters. It goes very well through 2.0 millimeters incision in wound assisted. It defolds, as you see, quite nicely, not too slow, not too fast. And the good news, another good news, is that the haptics don't remain stuck on the optic, as we, at least I, sometimes have with other hydrophobic IOLs. I rotate the IOL not in the final position, but with 10-15 degrees before the final position, so the markings of the cornea, before the markings of the cornea. A careful bimanual wash of the OVD, completely washing, especially underneath the IOL, as it has been said previously. Why is that? Because we don't want to leave any space between the IOL and the posterior capsule. Otherwise, we could have a rotation immediately post-op in a few minutes or hours. And after that, after finishing the complete washing of the OVD, we rotate again the last 15 degrees in the final position. Here again, the markings are quite short, so the pupil, if we don't have a perfect mydriasis, sometimes it's quite difficult to see these markings, or if there are some pseudoexfoliation, again, the surgeon must pay a lot of attention to these marks. They are well aligned on the markings. My markings on the cornea are done with very fine scratching with a 26 gauge needle, and after this fine line I have the colored, the dyeing of them. Now one can see better the final alignment and the good position, the desired position in a nice circular CCC, which is covering the margin of the IOL. So this is my experience. I did 16 eyes, but the last patient couldn't come for the last follow-up visit. So I have 15 eyes of 14 patients, age between 40 to 86 years. The follow-up was 1 month for 11 eyes and 2 weeks for the rest 4 eyes. The preoperative corneal cylinder was before 0.75 and 175. And this is the IOL that I use with this power. In terms of axis, I have only one with the rule astigmatism on 100 degrees, and all the others have been cases with against the rule astigmatism. I pointed this out because for me it's important when I recommend a toric IOL for a patient if we are dealing with against the rule or with the rule astigmatism. All eyes had cataract done by the same surgeon with the same preoperative marking technique, the same surgical technique with no intraoperative complication, no post-op complications. The visual acuity ranged from 0.8 up to light perception, and the corneal cylinder from 0.75 up to 175. The post-op visual acuity improved a lot, as you can see here, and the corneal cylinder remained pretty much the same, which was expected. But we had even a better surprise. We influenced quite a few. So the induced astigmatism was quite almost zero, except for patient number 3 and eye number 3 and eye number 10, which had 0.75. This can be seen better here. So most of the patient, 9 eyes of 15, had almost no induced astigmatism, and these 2 cases have more than expected. I don't know why all of the incisions have been done at a vertical position, 100 degrees. And these are the results for the 15 eyes as in terms of objective pre-op astigmatism and objective post-op astigmatism. As you see, the values that have been pointed before. Subjective refractive astigmatism is not always the same as you know with the objective, but there are no big difference. Anyway, the results are much better in subjective refractive astigmatism, so the patient were happy without any cylinder correction, or anywhere with lower than the objective value. Visual acuity improved a lot, as you can see. Uncorrected and best corrected visual acuity, there are no big differences, as you can see in the next slide. So our goal, except for the eye number 10 and the eye number 6, where there is a difference between the uncorrected and best corrected. In the other, the patient gained only 1 line, let's say, so we were pretty much in the target of the refraction desired. In terms of IOL stability, we checked for the IOL centration from lateral shift point of view at slit lamp and with photo. First day versus the final control at 1 month. All cases had IOL body completely covered by the CCC, so there was no lateral shift, markings aligned with the Burkinia reflex, no tilt at 1 month, and we also measured the rotational stability at the slit lamp and photo. What we did at the slit lamp is what you see here. We put a very tiny light and we measured the axis, but it has not been said. Must say it is very important, the head position, strictly vertical position. So it's not only a lot of a technical way to measure the axis, but one has to pay attention to the vertical position of the head. And again, now the first day post-op and the 1 month post-op, what we took some markings like this vessel here, or this one here, or this pigment here and here. And we made on the computer some lines. We don't have a special program for this, but I think it is available. We don't have it. And we made some marks, a line between this marking here. It's quite difficult to be seen from this angle. And from and between the markings. And this is how we measured the angle. And we managed to be quite precise, let's say. These are the results in the day 0, day 1, and 1 month, or for the last eyes, 2 weeks post-op. I highlighted here 3 eyes, which I was not happy with. They had 4 and 5 degrees rotation. Otherwise, all the other eyes had been, as you see here, 80% of the eyes, that means 12 eyes, had less than 2 degrees, and only 3 eyes had 4 or 5 degrees. I would keep in mind the 5 correct things that any surgeon who wants to start implanting toric IOLs: the correct K readings, the correct biometry, the correct preoperative marking of the cornea, correct and known value of the own surgical induced astigmatism and correct surgical technique. Having in mind all these previous issues, the refractive results are quite very good and the patients are very happy. In comparison with the standard IOLs, there is a small learning curve concerning the pre-op axis marking of the cornea and the IOL positioning on the right axis, so on the markings of the cornea. In comparison with other toric PC IOLs, there is no learning curve, as a matter of fact. Of course, a longer follow-up is necessary for the long-term IOL stability and refraction, and I'm thinking especially to the capsular bag changes. Sometimes, or most of the time, we underestimate the value of the bag changes in time, and that would lead to changes in stability and in refraction. And of course, it is too early to evaluate the PCO rate, but that will be with the future. Thank you.
Our last speaker will be Dr. Edoardo Ligabue from Milan, Italy, to spotlight on Envista Toric IOL, observing the real-life outcomes.
Thank you, Professor Field. Good evening. The dinner is approaching. Wait another 10 minutes. And go on. This is finally we will arrive at the results of the Envista registry. This is the financial disclosure. I will speak about the registry and my personal experience with the combination of Victus femtosecond cataract surgery and Envista toric implant. The Envista registry design is a study with 5 European sites in Spain, Germany, Netherlands, Slovenia, and Italy, and was screened 76 patients and 52 eyes with 1 to 2 months of follow-up. Only 48 patients was included in this analysis because 4 eyes has been excluded from the analysis because of the secondary surgery procedure and retinal disease. And the demographic shows a value of the IOL power between 15 to 25 diopters. The cylinder power, the half of the cylinder was 1.25, and then the other quarter was of 2 and 2.75. Then the female are in strong at the double of the males. The category age is more than 50% are between 70 to 79 years old. The incision size, this is interesting, the mean was 2.4 millimeter and varied from 2.2 to 3 millimeter. And other interesting data is that half of the surgeon prefer to put the incision on the step axis. The preoperative corneal astigmatism was 1.6, the mean, and the expected was 1.45. The calculated surgical induced varied from 0 to 0.5, probably due to the 3 millimeter incision. The main slide is this, because the mean cylinder reduction is very, very good, about 85% of the cylinder reduction. The manifest residual cylinder was 0.42, and 75% of patients were within 0.5 diopter. So this is an excellent result. And the total of the patient was within 1 diopter. This is a very impressive result for the toric IOL. And the IOL rotation between the operative and the 2-month post-op visit, the mean rotation was 3.6 degrees. This is a very low value because you know how difficult it is to measure to standardize the method of measuring the alignment of the lens during the surgery and post the surgery. And 3 degrees is a tolerance that sometimes occurs when you measure today and 1 month after the same patient. This is probably is more noise than a real misalignment of the lens. And the 95% of patients was 10 or less degrees of rotation. So in summary, we can say that Envista Toric IOL provided a number of beneficial features. Main cylinder reduction 85.3%, mean IOL rotation 3.6 degrees, and this is a data that is consistent with other lenses in the market, and high patient and high satisfaction also for the surgeon, because when the surgeon is happy, also the patient feel that all things are gone well. And a few minutes for speak about my personal experience with Victus, and this is a free paper that I explained this morning, talking about the resulting visual quality of capsulorhexis position and centration with femtosecond laser cataract surgery. The most of you well know the femtocataract surgery is benefit in talking about capsulorhexis, diameter, circularity, and centration in lens fragmentation. But the most important feature now that we can observe using a femtosecond is the IOL position, because the centering, the stability, the absence of tilt and of coma, due to the perfect circularity and centration of the capsulorhexis, this is what allows us to have a wonderful refractive result in the post-op period. And this is a very, very good aberrometrical evaluation with internal neutral LSA, with no internal coma, and with a good value of visual quality metrics, with a very good MTF and PSF in post-op. But I want to stress this slide because we develop with OPD-free aberrometer this display to evaluate the distance between the center of the capsulorhexis, evaluated with this cross, graduated cross, and the position of the CMK center, that is the fixation of the patient. And this is the data of 40 patients at 3 months follow-up, and the average is 0.1 millimeter. And I think this is one of the most important features now to understand for the femtosecond surgery. And 1 minute of video. I take out the capsulorhexis, well performed by the Victus, and just for didactical purpose, we can see how perfect is. And now I prefer to use a pre-chop for escape the bubbles from the posterior part of the lens. This is a hard cataract, and we can do easily after the division in 4 quadrants with the Victus. And then we are ready for the Envista Toric implant. Yes, we can see well the 2 dots. I would like to have dots more longer, just to see better when the pupil is small. And now an easy implantation, 2.2, wand assistant, and OVD well aspiration. It's very, very important, this step, and then align. A good hydration, and just finished. The Envista is very easy because unfolding is a little bit slow respect of the other lenses. So take-home messages, or better, take-dinner messages. Envista Toric provide astigmatic patients with predictable refractive outcomes and demonstrated excellent rotational stability in all clinical studies. The barometrical evaluation shows very good data, and at least the combination between femtocataral surgery and Envista Toric that allows well-centered capsuloresis and an excellent position of Envista helps to have perfect refractive result. Thank you very much.